Good morning, everybody, and thanks for joining us for Gymnastics Injuries, Treatment, Prevention, and On-Site Care. First, I want to introduce myself. My name is Megan Hunt. I'm the Vice President of Precision Athletic Training. We have been a consulting and contracting athletic training company since 2009 and have been providing BOC-approved CEUs since 2013. Our speaker today is Elspeth Hart. Ellie is a physician assistant in the sports medicine division at Boston Children's Hospital. She was a Region 6 Level 10 Junior Olympic competitor and gymnast in Massachusetts and was recruited for Division I gymnastics at James Madison University in Virginia. At James Madison, she graduated with a Bachelor's of Science degree in athletic training and sports medicine, and then went on to pass her boards as a certified athletic trainer. After a year of being an AT, she then went to Massachusetts College of Pharmacy and Health Science in Boston, where she received her master's degree in physician assistant studies. After passing her boards, she was hired by Boston Children's Hospital as a physician assistant in the sports medicine department, in the operating room and clinic. A year later, she started the first ever injured gymnast clinic, a clinic dedicated to the treatment, care, and prevention of gymnastics injuries. She's currently working on multiple research projects on gymnasts' injuries and injury prevention. Without further ado, Ellie Hart.
Good morning, everyone, and thank you so much, Megan, for the great introduction. I'm honored today to be selected to speak. Today, I'll be discussing gymnastics injuries, treatment, prevention, and on-site care. Here's an overview of what I'll be discussing today. I'll begin with gymnastics basics and then move on to specific gymnastics injuries in each body region. For each gymnastics-specific injury, I'll go over epidemiology, a brief description, mechanism of injury, history physical exam, treatment, and prevention. I'll then end the lecture today with gymnastics-specific on-site care and with the conclusion. Historically, gymnastics is one of the oldest sports and can be dated back to the ancient Greeks. There are different types and forms of gymnastics that we see here. On the far left-hand side, we see artistic gymnastics. This is the most commonly known, as well as the one that we'll focus mainly on today. To review over a couple other forms of gymnastics, first we'll start with rhythmic gymnastics that we see here in the middle of the screen. Rhythmic gymnastics includes the rope, hoop, ball, clubs, and ribbon events. These routines are performed on a 40 by 40 foot floor, which is the same floor that's used in artistic gymnastics. The next form of gymnastics is called trampoline and tumbling that we see here in the middle bottom portion of the screen. In tumbling and trampoline, this includes what's called power tumbling, trampoline, synchronized trampolines, and double mini tramp. The image that you see here is something called double mini tramp, which is one of the events that was just mentioned. The gymnast runs down a runway, does a series of saltos or flips, hits again the trampoline, and does another series of saltos or flips, and then lands on the floor exercise. Another form of gymnastics is called acrobatics that we see here in the upper right-hand side. Acrobatics combines of 5 different events. There's women's pairs, men's pairs, a mixed pair, a women's group which contains 3 women, or a men's group which contains 4 men. Each pair or group performs a series of routines that feature tumbling skills, partner balances, and dynamic skills. Routines are also again performed on a 40 by 40 foot floor, the same as artistic gymnastics. The last form of gymnastics is called team gym or power team gym that we see here in the bottom right-hand side of the screen. In team gymnastics, competitive squads of athletes perform 2 different types of events. One is called group floor exercise and the other is called a group jump. Squads are made up of 6 to 14 gymnasts and are judged based on the difficulty of the requirements and the execution of these requirements. Next, we'll discuss more in-depth artistic gymnastics. In women's artistic gymnastics, there are 4 different events that we see here: the floor exercise, the uneven bars, the balance beam, and the vault. Each routine, depending on the skill level, has certain skills which need to be included. There are then deductions that are given for each skill that is performed. Deductions could include flexed feet, bent knees, or not sticking your dismount, to name a few. In the higher levels, there are bonus points that are added to score for harder skills performed in a combination. The goal in the non-Olympic levels is to obtain a perfect 10. In 2006, the perfect 10 was eliminated from Olympic or elite level gymnastics. Scoring in elite gymnastics is now based upon a combination of difficulty and skill, with the more difficult the skill, the higher the potential score. The current average range up to 16 points, however, there is no upper limit to your score. Next, we'll discuss the men's gymnastics events in artistic gymnastics. In men's gymnastics, it includes the pommel horse, the rings, the parallel bars, the floor exercise, the vault, and the high bar. The men's gymnastics scoring system is also similar, with deductions for skills performed incorrectly or with errors. And in higher levels, again, bonus points are added for harder skills, as well as also in elite gymnastics, the same scoring system is also true, meaning that there again is no perfect 10, but instead it's based off of the difficulty of skills that you're performing. One thing I'd like to point out is notice the difference in events and emphasis on upper extremity weight-bearing events in men's gymnastics when compared to women's gymnastics. This will be important to remember when looking at gymnastics injuries. Gymnastics is a year-round sport, meaning that there's no rest period or time off. There are also different levels in gymnastics, the first being a recreational class or a beginner level, which may practice between 1 to 4 hours per week. Then there are competitive teams, which include the Excel or Prep Optional level, which is a program for all gymnasts to participate in and compete and practice between 4 to 10 hours per week. And then there's the Junior Olympic levels, which are levels 1 through 10, which is a select team that may practice between 12 to 30 hours per week. I always try to differentiate the difference between Excel and Junior Olympic levels by relating this to something that most people know, which is soccer. So when comparing prep optional gymnasts to the Junior Olympic levels, prep optional gymnasts would be equivalent to comparing a town soccer team where everyone can play and participate versus the Junior Olympic levels, which is more of a club or private soccer team where we have to be invited to compete and participate. Lastly, there's the elite level of gymnastics. This is the highest level that you can participate in. These gymnasts will train 2 times a day and up to 40 or 50 hours per week. This is a select group of gymnasts who are on the path to try to make the USA Olympic team. There are typically no more than 100 to 150 elite gymnasts in the country at one time. Gymnastics has specific equipment besides the events that we recently saw. Equipment that I'd like to point out today, the first being grips. These are on the left-hand side and in the middle of the screen. Grips are used to essentially grip the bar, as stated in the name, and help decrease the incidence of rips. Rips are calluses that form on gymnasts' hands from friction from the uneven bars, the high bar, or on the rings. For women, they use a 2-finger hold grip that we see here on the left. For men, they use 3-finger holds. Notice that there's a dowel in between on each grip. The dowel helps with rotation as well as helps grip the bar. However, as we'll learn later on, the dowel can also be very dangerous. The next type of equipment that we'll describe are beam shoes, which are in the bottom right-hand side of the screen. Beam shoes are used on either the balance beam or sometimes on the vault. The reason why they are used is they add padding to the calcaneus and the distal plantar surface of the foot when performing elements on harder surfaces, such as the balance beam. On the upper right-hand corner of our screen, we see something called a turning shoe. These have become more popular in gymnastics as they help decrease the friction on the foot and allow the gymnast to perform more turns on a foot on an apparatus such as the balance beam or the floor exercise. When watching elite level gymnasts, you may see one of these turning shoes on one foot, but not on both feet, and this would become very hazardous to the gymnast landing as they are very slippery. Injury rates in gymnastics range from 1.08 to 50.3 per 1,000 hours of exposure. This is an incredible range, and it's due to the fact that all these different studies did not take into account age, level, practice, versus competition injuries, and also type of gymnastics, as well as there are multiple other variables that were not included. I tried breaking down the age group by looking specifically at pre-collegiate versus collegiate levels. When looking at pre-collegiate gymnastics injury rates, The range is between 0.52 to 3.66 per 1,000 hours of exposure. In collegiate gymnastics, the range was between 9.22 to 22.7 injuries per 1,000 hours of exposure. Some reasons that could potentially be the difference between these two injuries is that once you've already gotten to collegiate gymnastics, you've already had multiple injuries, and therefore these may plague your collegiate career. More research, though, needs to be done looking at specific gymnastics injury rates as well as ranges per 1,000 hours of exposure. The most common location of injury in gymnastics is the lower extremity, specifically ankle sprains, followed by knee internal derangement. Gymnasts are also more likely to be injured during competition than during practice. On the bottom of our screen, I show the last 5 Olympics that have occurred. On the very far right hand of the screen, this would be our 2000 bronze medal Olympic team. Notice that there are 7 individuals on the team along with the alternates that are pictured. In Athens, Greece, which is the next team that we see here, again, we look to see that there is 2004, that there's now only 6 members of that team. Then looking at the 2008 silver medal team, there are 6 members of the team. In 2012, for the London Olympics, where we won gold, there are now only 5 members of the team. And lastly, at the most recent Olympics in Rio in 2016, there are now 5 members. There has been talk within the international gymnastics community that the spots may now go down to 4 spots for the team. This will then significantly decrease the chances of a young gymnast making the Olympic team, as we saw from 2000 going from 7 to now potentially in 2020 going down to only 4 spots. The majority of these injuries, roughly 70%, occurred on either landings in the floor exercise or on dismounts. The most common skills which cause injury to a gymnast are what's called back or forward handsprings and saltos. Saltos are also called flips, and a backward or forward back handspring is actually seen on the bottom of the screen by this cartoon depiction. There's also a 25-fold higher injury rate in the highest level of United States Gymnastics Federation as compared with the lowest level of competition. Next, we're going to move on to back injuries. The rigorous training schedule and competitive nature of the sport of gymnastics imparts great stress on the spine. Extension, axial loading, and traction forces are estimated to be 6.5 to 9.2 times the body weight of a gymnast during a downward ring swing. The most common causes of back pain in a gymnast include spondylolysis with or without listhesis, discogenic back pain, spondylogenic or mechanical back pain, Schumann's disease or atypical Schumann's disease, and vertebral body fractures. The prevalence of back pain among gymnasts ranges between 25 to 85%, with some studies noting the incidence of back injuries as high as 65 to 85%. This section will specifically focus on the spondy. To do a quick anatomy review, we see here the vertebral bodies combined with the vertebral discs. One particular structure I'd like to point out is the pars interarticularis. When looking specifically for a spondylolysis that from now on we'll refer to as a spondy, we see that there's a fracture in the pars interarticularis. For a spondylolisthesis or a listhesis, this is when the vertebral body breaks on both sides for the pars interarticularis and the spine then slides forward. In terms of who gets this injury, it is typically a gymnast in levels 4 through 6 who is skeletally immature. The reason why I mention specific levels is that in levels 4 through 6, the gymnast is doing a repetitive amount of hyperextension or arching-based skills. Again, a spondy is a stress fracture or fracture of the pars interarticularis structure. The mechanism is from repetitive hyperextension to the lumbar spine. When looking at the history and physical exam, the gymnast will complain of pain with extension or arching-based maneuvers. On physical exam, she or he will have tenderness to palpation on the L4 or 5 spinous processes, or well as on the sides. They also will have pain with extension and a positive stork test. The picture here below shows exactly what a stork test is. It's standing on one leg and then having the gymnast arch backwards. Typically, we have a provider standing behind, so that way just in case the patient falls or has a significant amount of pain, the provider is able to help. A positive test is when the gymnast arches back and has pain. Next, we'll discuss diagnostics. In terms of the diagnostics of a spondy, this is very controversial. Some providers like to do x-rays, MRIs, CT scans, or SPECT scans. In terms of my clinical practice, I usually begin with MRIs. If you were ever to begin with x-rays, one of the most important views to obtain would be an oblique view. This is a lot of radiation to the spine in a young athlete, so therefore that's why I choose to do an MRI first when possible. If we look here at the x-ray views, one important finding is what's called the Scotty dog, and you can see me sort of outline that Scotty dog there. Where the Scotty dog's collar is, that's the pars interarticularis, and when we look for a defect, we see that the Scotty dog's head is either decapitated or the collar has been released. And that would indicate that there is a fracture at this version would be at the L5 region. On the image to the far right that you see here, you see what's called a listhesis, or a slipping forward, as the pink arrow shows. On the bottom portion of the screen, we see an MRI. It's important to look at both sagittal, coronal views to see where that fracture is and to see if it's bilateral or unilateral. Sometimes I'll first obtain an MRI, and if the MRI is inconclusive and yet the story seems very predictable, then I may consider getting a specific level CT scan, such as a specific L4 or L5 region. Previously, maybe 10, 15 years ago, providers were doing a SPECT bone scan, and this is actually the most specific test to diagnose a spondy. However, this is a significant amount of radiation to a lumbar spine, specifically in female gymnasts who have a pelvis that we want to make sure we're not irradiating. In terms of the treatment, just like the diagnostics, it's somewhat controversial. Current treatment recommendations may include limitation of activity, specifically avoiding any hyperextension maneuvers, bracing, a bone stimulator, and physical therapy. I'm going to specifically discuss a certain type of bracing due to the fact that we are on the East Coast, and that's predominantly what we use. On the West Coast, though, providers are not providing any braces used for this type of condition. In my current practice, we use something called the BOB, or the Boston overlap brace that we see here. The gymnasts are in the brace for just about 4 months' time. However, I recently developed a new protocol that at 6 weeks, if the gymnast was doing well and had no pain on exam, as well as if I performed specific range of motion, strength, and gymnastic skills and they did not have pain, then they could transition into something called a transitional brace, which you see here in the second photo, for gymnastics activities. However, when they were not at gymnastics or at physical therapy, they would then have to be in their BOB brace. This is somewhat of a new idea. The way that I had come up with this idea and the way that I developed this new treatment plan was that our current head of sports medicine allows athletes to go back to sports and activities at 6 weeks as long as they have no pain in their BOB brace. The issue with the BOB brace in gymnastics is that you really can't move or bend at all. The transitional brace allows for a little bit more lateral bending, but helps avoid hyperextension, which is the main cause of a spondy. So my thought process was, as long as I prevented the extension, that I could allow the gymnast to go back and do things such as running, jumping, the uneven bars, still avoiding, of course, hyperextension skills and major dismounts. However, allow her to do some skills so that she's not out of the gym for a significant amount of time. So far, we've been doing this now for the past 6 months, and we've had great success. Gymnasts not only are going back to gymnastics easier, but we've also started preventing a lot more injuries as well. The other controversial treatment on this slide is something called a bone stimulator. At Boston Children's Hospital, we use something called a biomet bone stimulator. There really isn't a lot of evidence that proves that it works. However, current treatment recommendations include trying to obtain a bone stimulator to help increase, of course, bony healing. Moving on to prevention techniques, the keys are core and abdominal strengthening, increasing shoulder flexion, and increasing hip extension. I've shown a couple of exercises that I specifically recommend. However, I know that all of you can provide great exercises for core strengthening, shoulder flexibility, and hip extension, so by no means are these exclusive to this list. The core exercise that I chose to highlight today here on the left is similar to what would be called a dead bug, only what I'm having the athlete do is do a half sit-up or a half crunch. The reason I have them do the half sit-up or the half crunch is because in gymnastics, gyms are typically in a shape called a hollow body. A hollow body involves rounding your shoulders, but also tightening your abdominal muscles at the same time. I felt that this specific core exercise correlated very well with gymnastics, and that's why I chose to choose this today. Up here, I have a shoulder flexion exercise. Again, I try to be as gymnastics specific as I can. You see here the gymnast has her hands on a balance beam and then allows her head to drop down between her two arms. Notice that the gymnast maintains a very flat back. That's one of the keys to this exercise, is being sure that you're not arching from your lumbar spine or extending from the spine, but instead allowing gravity to increase your shoulder flexion. On the bottom screen here, we see the gymnast performing a hip extension exercise. In other words, promoting hip flexor flexibility. I recommend first having a coach or a gymnast help with this exercise, as we want to make sure that the gymnast has a flat back, as well as that this knee is being pulled down to the floor. Next, we'll discuss upper extremity injuries. First, I'll begin with discussing some basic principles of the injuries of the upper extremity, and then discuss specifically elbow, and then go on to the wrist. In men's gymnastics, the portion of upper extremity injuries are greater than lower extremity injuries. The most common upper extremity injuries location in men's gymnastics is the shoulder, followed by the wrist. The most common upper extremity injury location in women's gymnastics is the wrist, followed by the elbow. When thinking about the differences in men's and women's gymnastics injury patterns, remember that in men's gymnastics, the majority of events are upper extremity dominant when compared to women's gymnastics events. We'll start with the elbow. The repetitive high impact loading of the upper extremity that occurs during gymnastics can result in multiple elbow disorders. The most common elbow injuries are osteochondritis dissecans of the radiocapitellar joint, ulnar collateral ligament sprains or tears, medial epicondyle apophysitis or avulsion fractures, elbow dislocations, and tendinosis or tendinitis. We're going to discuss in detail osteochondritis dissecans or OCD of the capitellum. First, we'll just do a quick elbow and forearm anatomy review. Things that I'd like to point out specifically are the humerus bone, the radius, and the ulna, as well as the capitellum. An important elbow injury to discuss is osteochondritis dissecans of the capitellum. Osteochondritis dissecans, or OCD, is a condition that has been found predominantly in the elbow, knee, and ankle. There's a lot still to be discovered about OCD, and it's been surmised that this occurs from repetitive trauma to the bone, causing a lack of blood flow, which then leads to a necrotic bone or a loose body. The picture here shows the different stages of OCD. We see here in stage 1, or A beginning OCD lesion starting to form. This stage 1 does not affect the articular cartilage. In stage 2, we begin to see that the bone itself is now being affected as well as the cartilage. However, no loose piece or no loose fragments are able to be seen. In the third stage, we start to see that the OCD lesion is now hinging open. And lastly, in the fourth stage here, we see that the lesion has broken off and is now considered a loose body or a loose piece. OCD of the capitellum is found almost exclusively in gymnasts and young baseball pitchers. Again, the mechanism is from repetitive high impact stress to the elbow joint in what's called a valgus position, and the forces of the capitellum are then forced to withstand compression and shearing forces, which then leads to OCD of the capitellum. So how does this relate exactly to gymnastics? I wanted to show you all where we see that valgus and compressive forces. So I gave the example of a handstand. On the far left-hand side, we see an incorrect technique for handstand. Incorrect technique shows that the wrists are pointing outward and that the elbows are in a hyperextended position. This is an incorrect technique as it puts an extreme valgus load on the capitellum along with compression forces that we see here in this anatomy view. I then wanted to show listeners what a correct handstand would look like. That would mean that wrists are pointing forward, elbows are straight but not hyperextended, and therefore you're not having that valgus compressive force, and instead the forces are distributed evenly. When a gymnast would present in the office, he or she would state that there was some gradual onset of lateral or posterior lateral elbow pain. There may also be a loss of elbow flexion or extension, as well as locking or catching, in other words, mechanical symptoms of the elbow. On physical exam, the gymnast will have tenderness to palpation at the capitellum, along with decreased range of motion and swelling. This figure here at the bottom is just reminding us of where the capitellum is. In terms of diagnostics, X-rays are crucial. We see here on the X-ray view that the blue arrow is pointing directly to an osteochondritis dissecans lesion. Once an OCD lesion is seen on X-ray, an MRI is warranted. The reason is that you need to stage this lesion. Is it considered stable or unstable? Depending on what the MRI shows will then delegate what our treatment course will include. It's also important to note that these need to be diagnosed in a timely manner in order to avoid increased risk of progression to loose body formation. In terms of treatment, a stable lesion means rest from gymnastics, followed by serial evaluations and imaging, as well as physical therapy. Now, when I say rest from gymnastics, I specifically mean no impact on the upper extremity. The gymnast is still allowed to go into the gym and do conditioning in any skills that do not involve using the upper extremity. This is a point that I specifically try to mention to providers due to the fact that most providers will say, no, you can't do any gymnastics. However, because gymnastics is a year-round sport, the gymnast has to maintain her conditioning level as well as her other skills to continue to be competitive once she comes back from this injury. In terms of unstable lesions, the treatment is a surgical procedure. There are several different types of surgical procedures that can be performed, so therefore I'll kind of leave it up in the air on what those treatments are, as they're very specific depending on what type of lesion it is. The next injury I'll discuss is called grip lock. Grip lock occurs in any gymnast wearing grips. Gymnasts wear grips on the uneven bars, the high bar, or the rings. What happens is that while a gymnast is performing a circling element, such as what's called a giant or a clear hip, on one of the above events, the leather grip overlaps or folds, causing the hand to stay in place while the forearm continues to rotate, causing a forearm fracture. In terms of history and physical exam, the gymnast will describe an encircling element while wearing grips, immediate onset of forearm pain. There'll most likely be a gross deformity at the forearm, and tenderness to palpation at the ulna and radius. Diagnostics are typically performed in the emergency room, and X-rays will show a radius and an ulnar fracture. Treatment is extremely important. The medical staff and coaches need to be aware of this issue, as well as proper techniques to stabilize the athlete after such an injury needs to be put into place. If a gymnast is flung or released from the event, basic emergency planning should be in place, which may include airway, breathing, circulation, cervical stabilization, and possibly the use of a spine board. Typically, an emergent surgical procedure is performed with pinning to stabilize the bones. Prevention of this injury is simple. Have proper fitting grips. On the bottom here, there is a cartoon depiction of what grip lock is and how it occurs. Here the gymnast is about to swing around the bar. As they are trying to swing around the bar, the grip itself and the dowel folds over and gets stuck. Therefore, the gymnast continues rotating due to the fact that he or she has momentum, but the hand is locked in place, thus creating an acute fracture. On this first picture here, we see a grip that fits very well. The gymnast is holding onto the bar and we don't see any fold in the grip or the dowel. When we look at this picture, the dowel itself is folded over and there's a lot more space of that grip. This would automatically result in grip lock and thus an acute fracture and injury. One of the things that I always like to show is what is a good fit and what is a bad fit. On the left-hand side, you see a good fit. You see that the gymnast's fingers have to reach into the grip. In other words, it's not extending past her fingers, as well as the width is not bigger than her palm or hand. On the right-hand side, we see a grip that is way too long for this gymnast, as well as the width of the grip is almost as long as her palm. This is a grip that would be at risk for potentially grip lock. A lot of people, when they go to get their grips, send a handprint or measure their hand to a grip company, and the grip company is then responsible for fitting the grips properly. I also find that gymnasts and coaches are the best at knowing if their grips are considered a good fit or a bad fit. I recommend that if you're working with the collegiate team, just checking in with the coaching and staffing to ask how often do they check their grips. Grips can last anywhere from a month to 6 months depending on the level. Higher levels of gymnasts typically need to change their grips every 1 to 3 months versus lower level gymnasts may only need to change their grips every 6 months. Again, checking in with coaches and checking in with gymnasts at the beginning of the season every few months would be very helpful, especially if you're working with the collegiate team. Next, we will discuss the wrist. During gymnastics, the wrist can experience forces up to 16 times the body weight of a gymnast. This makes the wrist the third most common site for gymnastics injuries. The prevalence of wrist pain ranges from 46 to 79% of gymnasts, and there are reports as high as 70 to 88% of gymnasts who have wrist pain, however they may not report it. The most common wrist injuries in gymnastics include gymnast wrist, scaphoid fractures, a TFCC tear, scapholunate dissociation, scaphoid impaction syndrome, fractures related to grip lock, ulnar impaction syndrome, acquired Madelung's deformity, dorsal impingement syndrome, or wrist capsulitis, carpal instability, distal radial or ulnar instability, and ganglion cysts. We'll specifically focus on gymnast wrist. To do a quick overview of some wrist anatomy, I'd just like to point out the radius and the ulna. The green here represents an open growth plate, and that's exactly what we need to focus on when we're thinking about gymnast wrist. Typically, this will only occur in a growing or a skeletally immature athlete, again meaning that these are open growth plates. What this is that there is stress or fracture or injury to the distal radial physis or growth plate. Gymnast wrist results from repetitive compressive loading and shearing forces on an extended wrist. Examples of when a wrist would be extended would be in a handstand. A handstand, as we see in the upper right-hand corner of this PowerPoint, is a skill that's repeated and seen on multiple events, including the floor exercise, balance beam, vault, and the uneven bars. In terms of history and physical exam, the gymnast will complain of chronic wrist pain with no acute trauma. That's key here because in gymnast wrist, it develops over time. It's not one instance that causes this to occur. The gymnast will have on physical exam tenderness to palpation along the distal radius growth plate, as well as may have swelling, decreased grip strength, and pain with hyperextension and axial loading. The image below is a test that I like to do in the office. This is called an L hold. What we're doing here is we are putting specific hyperextension and axial load to the wrist. This way you can truly say, is this gymnast having pain with weight-bearing activity versus having the provider perform active wrist extension, which may not always cause pain. In cases of gymnast wrist, I found that 100% of the time in clinical practice, for me, this has been proven to show that the gymnast has gymnast wrist if they have pain with an L hold. Again, though, there are no studies that specifically prove this L hold test. However, for my clinical practice, this is what I've seen, and I hope that others can use this method as well. In terms of diagnostics, x-rays are key. I specifically mentioned an AP x-ray of both wrists for comparison. The reason why we want to do both wrists is we want to compare the size of that radial growth plate. I recommend that when they get this x-ray, they do the x-ray with his or her shoulder abducted to 90 degrees and with the elbow flexed at 90 degrees on the radiographic table. This is the best view to then measure the length of the ulna and the radius. We'll discuss further why this may be important. Sometimes, if the x-ray is negative and the gymnast is showing signs that are very positive for possible gymnast wrist, a provider may order an MRI. However, it's not always needed for a diagnostic case. In terms of treatment, it includes rest from gymnastics, physical therapy, and sometimes bracing or casting. This is one of the most difficult gymnastics injuries to treat. Gymnasts could feel better in 6 weeks and have resolution of images on X-ray then, or they could be out of gymnastics for roughly 6 months from impacting on their wrist due to this injury. I find this is my most difficult injury to explain to parents and to gymnasts due to the fact that I really can't give them an estimate on how long they're going to be out of weight-bearing skills in gymnastics. I try to be open and honest with them about the treatment, that this could last 6 weeks, or we could be dealing with this for 6 months. When returning back to gymnastics, it's crucial to slowly return to upper extremity skills. Di Fiore, who is a physician who wrote several papers on gymnast wrist, came up with something called the 75% reduction rule, meaning that when you first go back to gymnastics, you go at 25% for 1 week. If that goes well, then you increase to 50% the next week. And after that, 75. After that, you'll be back fully. This is a slow way to progress back to upper extremity skills without causing further injury. One thing I'd like to discuss with gymnast wrist is a complication called a positive ulnar variance. So one of the reasons why we want to get that X-ray view, specifically the AP with the 90-90 of abduction and elbow flexion, is to compare the length of the ulna to the radius. What happens in gymnast wrist that is not diagnosed early on is that the ulna then begins bearing more weight than the radius does. When the ulna begins to bear more weight, it begins to grow and get longer due to the fact that it's now having more forces, and therefore our body tries to help with these forces by increasing the size of the ulna. When looking at the specific X-ray view, we see an ulnar negative view. This is considered normal. Then we see here what's called ulnar neutral, which is also sometimes considered normal if you compare to the other side. However, when I get a gymnast who is at ulnar neutral, I discuss the possibilities that there could become a positive ulnar variance, especially if their growth plates are still open and they are still growing. On the far left-hand side, we see something called ulnar positive, so meaning the ulna is longer than the radius is. There's also a depiction of this in cartoon character form that I think might be a little bit easier to see. One of the reasons why we sort of worry about positive ulnar variance is this then leads to further injury down the road once their growth plates close. What happens is there's now undue stress to the TFCC and typically results in ligamentous tears. If a gymnast continues to have ulnar-sided pain after being diagnosed with gymnast wrist, I usually refer to one of my upper extremity surgical colleagues, and those gymnasts are typically put through a surgical procedure called an ulnar shortening procedure. Of course, we want to avoid this. So how do we do this? We have our gymnasts speak up early about having any radial-sided wrist pain, as well as make it known to the gymnastics community that if you're having wrist pain, this is not normal. That moves us on to some upper extremity injury prevention. Injury prevention should focus on proper technique, building upper body strength, speaking up if there's pain, consider limiting amount of torsion during periods of peak growth, and proper stretching techniques. On this first slide here, I emphasize increasing shoulder flexion. It's the same exercise that we saw for the spondy prevention. Another type of stretch that I like to include is a pectoralis, or an anterior chest flexibility. A lot of gymnasts, as well as a lot of non-gymnasts, have very poor posture with very rounded shoulders. If we can increase the mobility of their anterior chest flexibility, the hope is that then we're going to take pressure off the wrist when the gymnast goes to do handstands and other weight-bearing upper extremity skills. I typically only recommend the upper one with the foam roller for anterior chest flexibility if the gymnast has never had back pain or back issue, due to the fact that sometimes the foam roller can be a little bit uncomfortable, as well as some gymnasts tend to have lordosis or arching in their back, and this could create some increased pain. So if they've ever had back pain before, I recommend doing the lower one, which is being in the corner of a wall and stepping in towards the wall, therefore opening up your anterior chest muscles and stretching out your pectoralis muscles. The other type of strengthening that I'm sure you all are well aware of is shoulder strengthening with bands. So internal rotation, external rotation, flexion, extension. All of you are very familiar with these exercises. I'm not showing any groundbreaking, shoulder strengthening that everyone should be doing, but I do encourage my athletes to do these at certain times. For women's gymnastics, I recommend that they do the shoulder exercises prior to starting uneven bars, as this is the most predominantly upper extremity event. In men's gymnastics, I actually tell them to incorporate these activities into their warm-up prior to starting any event, because as before we saw, men's gymnastics has more upper extremity predominant events than in women's gymnastics. Also, it's important to remind our athletes and gymnasts to have good posture while doing this. A lot of the gymnasts will come in and try to do them as quickly as possible. And I say, hey, let's slow down. Let's make sure that we're doing these correctly so that we're strengthening muscles and not just going through the motions. I then wanted to mention some wrist strengthening exercises as well. Again, these are not groundbreaking wrist strengthening exercises, radial ulnar deviation, wrist extension, wrist flexion with bands. However, I found that these are important to do as gymnast wrist is becoming very prevalent and popular in the gymnastics community. So if we could make our wrist muscles stronger to absorb the forces better, this will help decrease our chances of having wrist injuries. In terms of gymnastics wrist specific injury prevention, what's key here is proper technique. So making sure that those wrists are not pointing out to the side, but fingers are pointing in front, if you remember that handstand picture from the OCD portion. Also, there's been a lot of discussion about wrist guards or supportive braces, which include the tiger paws that we see below here, or the skids that we see on this side here. However, no studies have shown if these are actually effective. I'm currently working on a wrist guard study at Boston Children's using force plates and 3D analysis to look at the forces and the angles at which the wrist, elbow, and shoulder hit the ground when performing both a front handspring and a back handspring, one wearing tiger paws, one wearing skids, and one without any wrist guards at all. I'm still working on collecting my data, and so as soon as I know, I can try to keep you guys all up to date on what I found and what I see. Another idea to prevent gymnast wrists would be decreasing the repetitions of elements on the wrist during periods of significant growth. So in other words, having a mom or a dad, or even a coach maybe, track the height of a gymnast. If they notice that the gymnast had a big jump in their growth, that this might be the time to avoid repetitive impact on the wrist and focus instead on maybe flexibility deficits that are now there, or maybe even strength deficits that have evolved due to the fact that the gymnast has grown. Again, reiterating, wrist strengthening exercises are extremely important, as well as shoulder strengthening exercises and maintaining flexibility. Next, we're going to discuss the lower extremity, which includes the knee, ankle, and foot. Just a quick overview we'll start with. The most common gymnastics injuries occur in the lower extremity. The injury rate ranges between 54.1 to 70.2%. The most common gymnastics injury is an ankle sprain followed by knee internal derangement. The most common injuries occur in the lower extremity. And we see here a male gymnast falling through the air, already grabbing his knee, which does not like it will be a great landing. And on the left here, I've just showed a gymnast, Ali Raisman, from Team USA, performing a leap on beam. You can imagine the height that she is getting from here and the forces and velocity that it's going to take for her to land back on that balance beam. Now we'll specifically discuss the knee. The knee had the largest portion of severe injuries when compared to all other gymnastics injuries. The knee was also the most likely body part requiring surgery in a gymnast. The knee, again, is reported as the second most common body part injured in gymnastics, the first being the ankle, and it is further noted that competition injury rates of knee internal derangement were 5.4 times that of practice. Gymnastics-related knee injuries include ACL tears, MCL tears, lateral collateral tears or sprains, meniscal injuries, Osgood-Schlatters disease, patellofemoral syndrome, and patellar subluxations or dislocations. Today, I'm going to specifically touch upon Osgood-Schlatters disease and patellofemoral syndrome. We'll again review over some quick knee anatomy. One thing I'd like to point out right here is the vastus medialis obliquus, as well as I'd like to point out the alignment of the knee itself. We see the patella centered, the patellar tendon, and the tibial tubercle. I'm not going to go into too much detail on ligamentous injuries such as ACL, PCL, LCL, or MCL, as I'm well aware that most of you are well adversed in this topic. So let's move on to Osgood-Schlatters disease. In Osgood-Schlatter disease, this will typically occur in a growing or skeletally immature gymnast. It's been found that gymnasts typically practice and compete during peak growth years, thus growth plate injuries are likely to occur. Daly, an author who studied this, explained that adolescence appears to be associated with the highest incidence of injury, which may be partially due to the growth process itself, inducing an imbalance between strength and flexibility. Daly also went on to further explain that he found that evidence that the growth plate cartilage is less resistant to repetitive stress than adult articular cartilage, and that the ligaments of children are stronger than the cartilage and the bone to which they attach, thus resulting in an increased likelihood of injury to an open physis. In terms of Osgood-Schlatter disease, this is an injury to the growth plate at the tibial tubercle for repetitive stress and traction of the patellar tendon. The mechanism is from repetitive jumping and impact. On the far hand right of the screen, we just see a breakdown of the anatomy and see exactly where that tibial tubercle is and where that inflammation and where the pain is. When looking at the history and physical exam, gymnasts will come in complaining of anterior knee pain, tenderness over the tibial tubercle. They'll describe some pain with jumping or running, and they'll have pain with resisted knee extension and a positive Ely or Eli test on exam. On the bottom screen on the left, we see a nice blue circle that indicates where that tibial tubercle prominence is. This is a dead giveaway that this patient may be suffering from Osgood-Schlatter disease, or perhaps when they were a younger athlete, they suffered from this. An Ely or an Eli test, discovered by Dr. Ely, is when the patient lies supine and the provider flexes the knee towards the gluteus. If the provider is unable to get the calcaneus to the gluteus muscle, this would indicate a positive test in quad tightness. It could also indicate a positive test, as we see here, that the hip comes off the table to compensate by trying to get the heel or the calcaneus to the gluteus. Both of those indicate a positive test indicating positive quad tightness. If you have positive quad tightness, this then automatically puts more forces and tugging on the patellar tendon and the tibial tubercle. In terms of diagnostic imaging, I recommend doing a lateral X-ray view. The reason is, of course, we want to look for any sort of avulsion fracture or injury. If there is an avulsion fracture or injury, this would significantly change our treatment and plan. On here, we see a normal tibial tubercle in the sense of showing Osgood-Schlatter disease, but then over here, we start to see the piece slowly pulling away. In terms of treatment, we recommend rest from gymnastics, physical therapy, and sometimes bracing. On the bottom corner of the screen, we see a Chopat strap. Sometimes gymnasts complain the Chopat strap falls off because they're sweaty or they're running or there's chalk. If that's the case, one of my best recommendations is to do pre-wrap around the knee several times and then roll it into your own Chopat strap. This pre-wrap Chopat strap I find fits the knee better as well as stays on and is not affected by sweat or chalk. Next, I'm going to discuss patellofemoral syndrome. Patellofemoral syndrome is a frequent injury in young, typically female gymnasts. It's described as abnormal tracking of the patella, and it's found more in females than in males due to the increased Q angle that causes the patella to track more laterally. This lateral tracking of the patella can lead to further injury, including chondromalacia patella, patellar subluxations, and patellar dislocations. Typically, our mechanism is repetitive forces on the lower extremity with this increased Q angle. When looking at history and physical exam, gymnasts will present with chronic knee pain in the shape of a C. We'll also see on exam decreased muscle bulk of the vastus medialis obliquus. There'll also be a positive Ober's test, as we see here demonstrated on the side. In an Ober's test, a positive test would indicate positive IT band tightness. If the IT band is tight, then it is then causing more lateral forces on the knee, which then causes the knee to again track abnormally. One diagnostic imaging that I sometimes recommend is doing an X-ray, specifically a sunrise view. On the right here, you see a very drastic image. I don't expect to typically see this. It's also showing actually a loose body piece there as well. But what I usually look for is in the trochlear groove itself. Is it a flat trochlear groove? Is it not as deep as we'd like it to be? Is the patella just naturally sitting laterally when we bend or flex the knee? These indications may help us further our treatment due to the fact that this patient may be down the road of having subluxations or even dislocations of this kneecap. So therefore, our treatment might vary slightly. In terms of patellofemoral syndrome for treatment, my highest recommendation is first beginning with physical therapy. Getting on a good VMO strengthening program, IT band and hamstring flexibility, as well as anti-inflammatory agents are crucial. A study done at Boston Children's corrected 50 to 80% of patellofemoral syndrome by doing the above recommendations. What's important to note, though, is that patients need to get up to 8 pounds of ankle weights when performing straight leg raises and maintain those 8 pounds for 3 months in order for their patellofemoral syndrome to go away completely. I think it's important to remind athletes the importance of continuing their straight leg raise program even when they feel their pain has gone away. Other knee injury prevention besides straight leg raises includes proper landing mechanics, using band walks such for gluteus and hip strengthening, and switching hip flexor, quads, and IT bands. On the bottom portion of the screen, we see landing mechanics. In gymnastics, you can land with your feet apart. However, the rule is that you must be able to click your heels together, as you see in this photo here. If you are unable to click your heels together, you will get a deduction for having your feet too far apart. In gymnastics right now, there is a shift in trying to promote this feet apart landing. However, in women's gymnastics, it's considered not aesthetically pleasing to land with your feet apart. However, I'm hoping that by talking about the science and the safety of landing, that we can help promote better landing mechanics in our gymnasts, and I hope you all will help me do so as well. Next, we'll discuss the ankle and the foot. Multiple studies have shown that ankle sprains is the most common injury in gymnastics. Cruz, another author who studied several gymnastics injuries, noted that the foot experiences loads of 3.4 to 5.6 times the body weight of a gymnast during a takeoff for a back handspring, which is that element that we showed before. The Achilles tendon during a back takeoff experiences forces measured at 16 times the gymnast's body weight. That's a lot of forces that are being imparted on the ankle and foot. The most common gymnastics injuries that occur in the ankle and the foot are lateral ankle sprains, stress fractures of the tibia or fibula, talar OCD, distal fibular physeal fractures, anterior ankle impingement, posterior ankle impingement, posterior tibialis tenosynovitis, talar fractures, Lisfranc injuries, stress fractures of the metatarsals, tarsal or navicular injuries, turf toe, calcaneal stress fractures, and calcaneal apophysitis or Sever's disease. Today, we'll specifically focus on lateral ankle sprains, talar OCD, and calcaneal apophysitis. First, we'll again review over some basic anatomy. Areas I'd like to point out specifically would be the talus, as well as the calcaneus. On the ligamentous imaging, I'd like to point out the ATFL, the CFL, and the PTFL. Again, ankle sprains are the most common injury that occurs in gymnastics, and it occurs most commonly during takeoffs and landings. This can occur at any age and any gender. Typically, it's an unexpected inversion motion to the ankle. Gymnasts will typically describe a feeling of "I rolled my ankle." We see down here the image depicting what an inversion or lateral ankle sprain is. On the far right-hand side, this is a famous picture and a famous vault from the 1996 Olympics with Carrie Strug. Carrie Strug went on to do her first vault, ended up falling and having actually an inversion ankle sprain. Carrie, though, had to compete one more vault and had to land on her feet in order for the USA women's team to win Olympic gold for the first time. Carrie prepared herself, sort of rested her ankle for just a minute, got ready to do her vault, and did her second vault, landed on her feet. However, as the famous middle picture shows, she immediately lifts up her left leg as this is her injured side. The USA did go on to win the first ever team gold in the 1996 Olympics, but Carrie Strug did have a pretty significant injury to her left ankle. In terms of history and physical exam, I'm sure you guys are well versed in lateral and inversion ankle sprains, so I don't really go into too much detail, but of course, They'll describe a rolling of the ankle, swelling, bruising, and lateral ankle pain. Sometimes we do order x-rays, sometimes even MRIs. It really just depends on each case. I like to use the Ottawa ankle rules to help me determine if I need to order further imaging, such as an x-ray. Typically, if the patient is skeletally immature and has any bony tenderness on a growth plate area, I automatically get a series of x-rays. In terms of treatment, it's somewhat mixed amongst providers. I typically first discuss immobilization with a tall air cast boot and crutches. Once a gymnast though feels good, I discuss decreasing the use of the crutches and then eventually decreasing the use of the tall boot with the help of physical therapy or with their athletic trainer. When returning back to gymnastics, I recommend ankle taping and bracing. The next injury I'll discuss is talar OCD. Similarly to in the elbow, this is the same OCD that we're talking about. This again occurs in growing and skeletally immature gymnasts. It's been surmised that this occurs from repetitive trauma to the bone, causing again that lack of blood flow, which leads to a necrotic bone or a loose body. The mechanism is from something called a short landing. And we see this girl kind of landing with both ankles. A short landing means landing in a hyper dorsiflex position multiple times. What that means is an under rotation of a skill causing your talus to jam into the tibia. On history and physical exam, the gymnast will explain that he or she has anterior ankle pain and will show tenderness of the anterior ankle and swelling. The gymnast will also have pain with an anterior drawer test. You might not feel any ligamentous looseness or instability, but when you pull that talus forward and you're pulling the foot forward, it may nick or hit the tibia and therefore increase the patient's pain. Imaging is crucial to this diagnosis. Similar to OCD in the elbow, we need to do that x-ray. Upon getting the x-ray, an MRI again is needed as we need to stage the lesion. Is it loose or is it unstable? Treatment for OCD in the talus is rest from gymnastics, typically a short air cast boot, possibly crutches depending on the stage of the lesion, and physical therapy. For unstable lesions, it's typically immediate surgery. The last injury I'll discuss today is calcaneal apophysitis, or Seaver's disease. This typically is in the growing and again skeletally immature athlete with open growth plates, and this is similar to Osgood-Schlatter disease by mechanism, but occurs at the posterior calcaneal physis, where the Achilles inserts. It occurs from repetitive jumping and impact activity. Physical exam will typically show chronic medial or posterior calcaneus or heel pain, swelling at the calcaneus or heel, tenderness palpation at the medial aspect of the calcaneus, tight heel cords or tight Achilles, positive squeeze test. Down here on the bottom, we see a picture of what a squeeze test is, which is taking the heel in the provider's hand and giving it a good squeeze. If there's pain, this is considered a positive test. In terms of diagnostics, I do recommend doing specifically a lateral x-ray view. The reason is you want to be sure that there is no fracture in this heel itself, or even a stress fracture. Gymnasts are imparting so much force, as we discussed earlier, 16 times their body weight on their feet. So there is a high possibility and likelihood that there could be a fracture, or even a stress fracture in the calcaneus or this area. Therefore, by obtaining an x-ray, you can help rule this out. Treatment for Seaver's disease includes rest from gymnastics, specifically impact and pounding, physical therapy, and bracing. There are two braces down here at the bottom. One is called a cheetah brace, which is essentially a Thule heel cup put into a sleeve, and the next is an X brace over here. One of my colleagues is actually working on to see which brace is more effective. As soon as I have those results, I'd happily pass them along as well. In terms of injury prevention for foot and ankle, proprioception is key. I encourage all gymnasts and all athletes to do proprioception and balance work. I first begin with eyes open, then progress to eyes closed, and then progress to catching a ball back and forth. Other prevention exercises for strength include band exercises, doing dorsiflexion, plantar flexion, inversion, and eversion. Lastly, I recommend that gymnasts with any foot or ankle injuries specifically do stretching of the Achilles. One way that I show how to do it is by having the front foot up in dorsiflexion, first by toes pointing up to the side, then next toes laterally or out, and then next toes in or medially. Once you're in one of those positions, with the back foot, you rise up on your toe to create a stretch in your front foot. I find that this helps stretch out all of the gastrocnemius, including the soleus as well, and gets the gymnast prepared and ready to do their first event or skill. Lastly, we'll move on to on-site gymnastics care. On-site gymnastics care, there's a few questions that you need to ask yourself prior to having coverage. The first is, what gymnastics discipline will you be covering? Artistic, trampoline, team gym, or rhythmic? Each discipline of gymnastics has slightly different risks involved, and therefore you need to know what you'll be covering. The next is, what is the location? Is it in a gymnastics gym that we see down below? Is it in what's called a podium style? Is it in a hotel or convention center? The reason why you need to assess the risks is that in a gymnastics gym, there's more padding and there are crash mats available. On a podium style, the events themselves are lifted up above the ground by about 4.5 to 5 feet high, so there's a risk of falling off the apparatus. If it's in a hotel or in a convention center, typically these events are placed only on a cement floor, meaning that the forces that are going to be imparted on the gymnast are significantly increased when compared to a normal gymnastics gym or a podium, for example. Next, you need to know what other meet personnel are going to be there. Other meet personnel could be the meet referee, the meet director, coaches, parents, fans, media, janitorial staff, equipment crew. There's a whole group of people that might be available. You need to know who will be on site. One person you should always check in with when you arrive is the meet director. They will tell you where you are, what you have for setup, and if there is any emergency people that are on site. The next question is, are there on-site or off-site practices? In big competitions throughout the US as well as abroad, sometimes there'll be a practice facility as well as a competition floor. You need to be aware of where you'll be located and if you'll need other athletic trainers or staff to help you cover. Another question is, will you be offering recovery time after competition or practice? Some of the bigger events allow prevention and recovery sessions to occur after the times of the practice and competition. These sites may include ultrasound machines, e-stim machines, Normatec boots, and other different sort of recovery elements. And so it's important to know, will you be also covering those as well? Lastly, is there consent to treat for minors and documentation available? Most of these gymnasts are below the age of 18. So who is traveling with them? Are their parents there? Do they have consent to treat? Of course, in an emergent situation, you treat no matter what. However, in a non-emergent situation, you need to discuss with the parents or the coaches if your treatment is okay to perform. Other things to consider are, is there an emergency action plan in place? Whether you're in a gym or a facility, where's the closest hospital? You need to know what actions you're going to take. Along with, is there an AED that's on site? Where is it located? How can you get to it? Also, where are you going to set up your table and where's your setup going to be? I recommend that if you're doing just a traditional, what we call either a convention center or a gym competition, is setting up in the middle of the competition area, as multiple gyms will be performing on multiple events at the same time. And this will give you the best visibility to see everyone. I do understand that you will be more in the middle of everything, therefore you might block views of parents and such. However, this is a crucial place that you need to be, as you need to be visible so that coaches and parents know to grab you if there's an injury that perhaps you don't see. I also recommend that for higher levels 8 through 10 and at elite competitions that you always have EMS personnel on site. Levels 8 through 10 are level 8 through 10 and elite are the highest risky, or the most risk involved in those gymnastics competitions. So therefore you need to have someone available with possible spine boarding, splinting, and the ability to transport quickly and efficiently. Next, I'm always asked about spine boarding and the foam pit. My best advice is practice, practice, practice. With the new guidelines about spine boarding, perhaps we will change the way that we use in the foam pit. However, again, my best advice is calling your local EMS service, fire department, and discussing how are you going to work together to extract this patient. The recommendations by USA Gymnastics is that first you would put on a cervical collar. The ways to do this are mentioned that you can put a panel mat, which is a smaller mat, into the foam pit, have one provider step on the panel mat so that it decreases the risk of movement, and then after that, putting more panel mats around the patient so that way you're decreasing movement. However, if any of you have ever been in a foam pit, you realize how tricky and unstable the surface is, and so I again recommend practice, practice, practice. Lastly, thinking about blood spills. On the bottom here, I just posted a little funny picture of what sort of gymnastics posts about their wrists. So you mentioned earlier that grips are put in place to prevent rips or calluses that form on the hand. Typically, there are at least 1 or 2 or even 5 blood spills per competition. My recommendation when cleaning up the blood spill is to first apply your solution to a sterile gauze and then wipe the equipment with it. If you were to spray the equipment with your cleaner, you create a very unsafe environment for the gymnast due to the fact that this solution is very slippery. If by accident you do end up spraying the equipment, I recommend just after cleaning the area, applying a lot of chalk to the area and notifying the judges, as well as notifying the gymnast that this may be an area that is slightly more slippery and therefore could someone please test the equipment. Additions to put into your normal ATC kit that I have found to be extremely helpful is tan skin or pre-wrap and tape. The reason is that the gymnast cannot compete with white tape as they get into the higher levels, as it's considered a distraction to the judges. I also recommend having an eye kit available due to the fact that chalk, eye glitter, hairspray, and such can get into the eye and therefore cause a gymnast to have an eye injury. And if you have the proper equipment to assess this, you'll be able to help them out. Another thing in your kit is nail polish remover. Now, a lot of people laugh at me when I sort of say the suggestion, but the reason is the gymnast is not allowed to compete with his or her nails painted. So therefore, they will get a deduction if they have their nails painted at a competition. So by having this in your bag, you're helping decrease the chances of a deduction. There's also gymnastics-specific equipment that you can include, such as having a pair of what I call like wristbands for bars. You can even throw in a couple extra pairs of grips, those bean shoes, tiger paws, wrist guards. Typically, gymnasts have their own specific equipment, but it's always good just to give them options in case they're traveling and they forgot something. Typically, again, this equipment is very gymnastics specific as they've worn these grips or worn these beam shoes for several competitions, so they're considered broken in. However, it is important to have stuff available if they do need it. Other sort of extra things are hair ties and clips just to throw in. As we see, they're always doing fancy hairstyles, and so just having that available is sort of a courtesy of care. And lastly, which everyone always questions me on, is I have balloons and Vaseline available. The reason why is if a gymnast gets an acute rip on her wrist, what you can do is you can put Vaseline, just a small portion of it, into a balloon and then place that balloon with pre-wrap and tape around his or her wrist. What this will do is this will help decrease the friction forces on the wrist and therefore decrease the pain from having a new rip or callus formation on the wrist itself. Other just specific gymnastics gym recommendations would be to look at proper placements of mats, making sure that people don't trip over them and cause injuries just due to lack of positioning, educating proper staff on coaching and spotting technique. Every coaching staff now has to go through USAG Gymnastics, what they call specific training. So they must have a certain level before they start coaching, making sure that all equipment is up to date. Typically at competitions, you'll see that that there is an equipment manager available. Sometimes it's a company called AAI, or there are other sort of international brands that are used. These people are there to make sure the equipment is placed safely as well as up to date, as well as making sure that nothing will sort of come out of place as a gymnast is using that. It's also really important to encourage your gymnast to speak up if there's any pain, as well as consider limiting any impact by rotating events or doing any sort of cross training or strength training. So lastly, we'll just do a quick conclusion of what we kind of learned over today. So important injuries to understand when treating the gymnastics population would be a spondy, OCD of the capitellum, grip lock, gymnast wrist, Osgood-Schlatter disease, patellofemoral disorder, lateral ankle sprains, OCD of the talus, and Sever's disease. Also, don't forget that the most common injuries occur in the lower extremity, specifically an ankle sprain being the first, and knee internal derangement being the second, as well as some of the most common event causing injury is the floor exercise. And this usually occurs during a back handspring or a salto or a flip. Thank you so much, everyone. I could not be here today without my family, friends, and colleagues who have gotten me here, so a special shout out to them. Now I'm going to open it up to questions. I think Megan will read them out loud, and then I'm happy to answer any questions that anyone might have. Thank you.
Okay, I do actually have a couple of questions myself.
Awesome.
I just want to remind everybody to please download the the handouts, the evaluations and assessments. If you haven't done so already, please do so now. You can email these back to me. My email address is mhunt, M-H-U-N-T, @precisionat.com. Or if you prefer, you can fax it back to 617-744-0551 is our fax number, 617-744-0551. My first question is something that I don't think you touched on, concussions in gymnastics, and most specifically return to sport, and if there's a sport-specific protocol that it was more common in gymnastics due to the inversion and rotation components that aren't common in other sports.
Yeah, no, great question. I would have loved to touch upon concussions, but actually by looking at sort of what the most common injuries are, concussions are actually not the most common in gymnastics. So that's sort of why I left them out today, but happy to discuss them. So one of the things that I always discuss about concussions, especially with the history and physical exam, is doing a best test. So the feet together, tandem gait, and a single leg balance. I don't let any gymnast go back, of course, if they have any symptoms. However, this is my best test to do because a gymnast should have perfect balance. So if at any time they're sort of deviating from a normal balance ability, I automatically say we're not ready to go back, even if they are completely symptom-free. When returning back to gymnastics, I discuss a progression which includes starting with what's called leaps, jumps, or turns, and non-flight elements. So non-flight elements are handstands, cartwheels, anything where your hands don't really push off or leave the ground. If they have no symptoms for this for 1 week, then I progress them to flight single elements. So that means a back handspring, a front handspring, but nothing in a series of elements. If this goes well for a week, then I progress them to what I would call series flight. So meaning flight elements that are done together. So tumbling passes, and that's when I start introducing vault and dismounts. So it's truly a 3-week progression back. And I think that this has helped gymnasts as it helps them sort of say, what can and can't I do? I also limit numbers as you're going back. Some concussion symptoms, as all of you know, can last anywhere from 5 days to up to 5 months even. And so these gymnasts have been out of the gym for a while. So to let them to do skills again, I suggest only doing 5 or less of each skill per event per what week they're on. And I found that that's been very helpful about progressing back and avoiding new injury as well.
Great. We have a question about the panel mat, the piece of equipment that you mentioned. Yes. Panel mats are usually about an inch thick, 2 inches thick.
Correct.
And
yep.
They fold, they're a little bit more firm than regular mats, and they fold up to about 12 inches so that, and they unfold to about an inch or 2 inches so that you can have a little bit more stable of a surface.
Correct, yeah.
For that.
Yep.
It looks like we have questions on OCD injuries. I'm not sure what the question is. Alan, can you specify a little bit more what your question is? And also, do you have a picture of the Vaseline in balloon positioning at all?
I do not, but I can sort of describe it for you if that would be helpful. Sure. So essentially picture sort of palm up surface, and wherever the rip would be on the wrist itself, you would place that balloon over that area or that callus. And I usually try to do with so I tie the balloon off so that way the Vaseline, of course, does not go anywhere. And then I would pre-wrap around it so that it stays in place, and then I apply tape over that so then that way it doesn't slide or move as the gymnast puts on a grip around that area.
Now, would you do that just on the wrist, like below where the grips strap in, or would you do that on the hand where the gymnast will grip the block?
So great question. I haven't really found a great way to sort of prevent friction on the hand itself, because you can imagine the wrist is moving, the hand is moving a lot on the bar. So this is specifically for the wrist. If there is a rip on the hand itself, there's something called a tape grip that can be created. Typically, though, the coach or the gymnast will make his or her own tape grip because it's pretty specific to the patient's sort of palm and wrist size, as well as coaches are kind of trained throughout their training on how to do this. But that's definitely something in the future that I might incorporate a picture on so athletic trainers can also make them as well. But my suggestion would be, if you're interested in learning more about like sort of rips and care of rips, is actually talking to the coaches and the gymnasts, because they'll be happy to show you, how to do this tape grip, as well as how to do this sort of balloon and Vaseline trick. They're very prevalent amongst sort of the elite and higher level gymnasts. These are the strategies that I've used, as well as other teammates have used, to help kind of decrease that friction or the forces where you do have a rip.
Okay. Another one of my personal questions is, can you talk a little bit about high school gymnastics and how that relates to the USAG levels and the club gymnastics that you spoke about?
Yeah, definitely. So high school gymnastics is sort of another subset of gymnastics levels, and it's sort of delegated by your state and your high school about sort of how many people you can have on the team. Typically, a team varies between anywhere as small as 5 gymnasts up to maybe even 25 gymnasts. So the rules differ in the sense that they want high school gymnastics to be more inclusive. So skills that are done in what's called the USAG system, so that prep optional, are the levels 1 through 10. They're changed so that the levels and the rules are a little bit easier. So for example, someone could do a tumble pass on floor that would maybe be considered a level 6 or 7 tumble pass in the JO level. However, they would get full credit if they were doing it at the high school level and get a higher score for that. The rules themselves are a little bit kind of difficult to go into, but essentially the best way to describe it is that the skills are valued, sort of easier skills are valued at a higher level when you compare them to the USAG level. I usually recommend gymnasts who are transitioning from the club to high school sport is to actually talk to the judges. The judges are incredibly helpful in high school gymnastics, and they will sit down with you and say, hey, here's what we were missing in our routine, or here's something that you can add in that will be a bonus for you that maybe you didn't think of that you can't do in the USAG levels, but you can do in high school levels. So high school tries to be a little more inclusive, similar to that prep optional level. I would say that those skills are kind of evenly matched.
And I know from both myself competing in high school gymnastics and also working events with high school gymnastics, there are a lot of young women who have never done gymnastics before but try out for the high school team. And I've noticed that there's a higher risk of injury from those girls trying to get the same or a similar level of difficulty as the girls who have been doing gymnastics for a while.
Yes, definitely. And that's a good point to point out. I always recommend too, for athletic trainers, people who are at competitions, is, checking in with the coaches and saying, hey, is there anybody here who's having a rough day, or anybody I should keep an eye on? Because I agree with you, Megan, there are girls who join the high school team who have never done gymnastics before and are trying to do skills that they have never either developed the basics to learn how to do that skill and just want to kind of get as many skills as possible at sort of any risk involved. So I think that's definitely a discussion to have with coaches and sort of say, hey, is it safe to try this event, or is it safe to try this skill? And even if you see sort of someone who maybe had a tough fall in warm up, just kind of going over and checking in with the coach as well as checking in with the kids. Hey, how are things going? Is there something we can do differently? And I think what's great and helpful, especially with you, Megan, is the sport. And so I think it's easy to talk the talk and lingo if you've been in the system, and that helps make the gymnasts feel a little bit more comfortable and help you actually give a recommendation of maybe a skill that might be more helpful for that athlete as well.
Another thing that I think about when I'm personally working gymnastics meets is I usually don't watch the competition. I watch the warm-ups.
That's a great advice as well. Yep, the warm-ups tell you a lot about what's going to happen, definitely.
I feel like when an athlete is scared of a skill and relying on their coach to help them through it, to spot them through it during warm-ups, or if they're starting a skill and not completing it during warm-ups, or if it just looks really scary, like if they don't look like they're getting the rotation that they need, I always make sure to watch those athletes in particular in the competition so that I'm more prepared for a possible injury when the coach is not there helping them, and they might get scared and not complete the skill to the best of their ability.
Yeah, definitely. That's great advice. I agree 100%. Your warm-up really does tell a lot about how you're going to do. There are, of course, sort of the odd cases or sort of the good cases where someone who's maybe nervous to do a skill competes greatly, but then there's also sort of the more likely case, which is the gymnast who's scared to do a skill doesn't always quite work out as well as they would like to. It's definitely keeping the nerves as a factor as well for competing.
Okay, so I think that's all the questions we have.
Okay, awesome.
Thank you so much, Ellie. This has been fantastic. We really appreciate you taking the time on a Sunday morning to go over all of this with us. Again, please download the evaluation and assessment forms and email them back to me or fax them back to me. It doesn't matter either way, and I can get you out your statement of credit as soon as I get those forms in. And have a wonderful afternoon, and go Patriots.
Thanks so much, everyone.